Alexey will join us this year. And it's my pleasure now and honor to introduce Associate Professor Alexey Pavlichenko, who is the senior lecturer in the Education Center, one of the most famous clinics, mental health clinic named after Alexeev in Moscow, and the lecture of Associate Professor Alexey Pavlichenko will be devoted to a very important topic of using digital technologies and modern technologies in psychiatry. So, Alexey, you're welcome to the stage.
Can I start? Oh, great. Okay, thank you, Daria, for kind introduction. Also, we are using the Betwe mixed state scale in our work. Now we are working at biological markers of depression, and also we have started to use this beautiful instrument. Yes, and we will collaborate with Daria to validate this test. Today, I'm going to talk about modern technology in context, firstly, of affective disorder, including bipolar disorder, and before the artificial intelligence, machine learning, very shortly, which help us to diagnose and manage firstly severe mental disorder, affective bipolar disorder and schizophrenia, PTSD, and other disorder where AI and apps are also quite popular and becoming more and more popular. Today, we are living in the era where most of the population in America, about 80–85% of the population, have a very powerful computer in their pockets and in mobile phones, and even in the poorest countries in Africa, where people can have problems in accessing water and electricity, they can have mobile phones. And it would be quite reasonable to use mobile phones and also machine learning, especially in developed countries, as in developing countries, which help us to treat and diagnose mental disorder in general. But firstly, I would like to speak which problems we as psychiatrists are facing while diagnosing psychiatric disorders. Before the DSM-3, psychiatry traditionally has offered clinical insight into observation, behavioral observations, and study of emotions and cognitions. Then we, after DSM-3 was launched in 1980, we were focused on very strict criteria of mental disorders, including affective disorders. Now we used DSM-5 for about 8 years, and we are about to start using ICD-11 in a year. And problems which we're facing, as I mentioned, are quite big. As the slide shows us, problems which, according to Alan Francis, before DSM-5 was launched 8 years ago, he represented these problems. DSM-5 just only dictionary which create labels and divide them itself. And DSM and ICD in general classification has become a surrogate for behavioral observations, and we have to focus on very strict symptoms, and sometimes we don't know what happened beyond the problems which we are facing in our room, in our clinic, and lack of validity, also the problem of the DSM-5, etc., etc. And also we have to mention very interesting work of Jan Banos before also. The DSM-5 was introduced, and in his work, which he called Precise and Diagnose for Psychiatry, he used so-called context diagnosis, and afterwards different model apps also followed this idea to use computer, to use smartphone, and patient, a client may get 10 times per day SMS with questions to understand, to assess his mental state, anxiety, being paranoid, happy, low mood, etc., and which context they happened in, for example, in context of stress, company, after taking medicines, etc., etc. And also we can understand the influence between symptoms in the context of different situations, and of course using this instrument so-called context precise diagnosis by diagnosis, we can understand much better what happened beyond our room auditorium, and it would be very relevant for manage our patients. And in this case, patients is not is a part of our team together with doctors, with psychologists, because we together we can understand better different factors which contribute to our condition. And the last year, Mario Mai and other prominent professors published a very interesting paper regarding precising diagnosis in depression. And last issue of both Psychiatry have published problems which were in context of schizophrenia and psychotic disorder. And according to Mario Mai and other professors, when we're facing with depressive patients, we need to think not just only about symptoms, not about subtypes of depression, but other parts of this domains are very important. And it would be quite difficult to assess all these topics, personality traits. The previous lecture, Giuseppe was telling me about temperament, the background for bipolar disorder, protective factors, resilience, cognitive schemes, and most of these domains, and some of these domains would be quite difficult to assess just only using DSM-4, DSM-5, sorry, ICD-11, also different questionnaires and scales, which may tell us just only information, just very low information, not all information about the patients. That's why we need to use additional instruments, and artificial intelligence and mobile apps are the most popular instrument which help us to understand better different domains, depressions, not only depressions that are bipolar disorder, etc. Also, we need to understand, we need to remember, being clinicians, that depression are different from our point of view as clinicians. There are different perspective of patients and different perspective of researchers, and they are not the same. Yes, and when we when we are thinking as clinicians, we are thinking it's only about only our way, but it's researchers and patients are the different. And it would be just 2 years ago, it was published a very interesting study of German psychiatrists in collaboration with other psychiatrists from different countries, which from Brazil, Canada, Mexico, Korea, USA, France, Italy, also some of them, our Italy colleagues participated in this very interesting online survey, which includes patients, more than 2,000 patients, and healthcare professionals, psychologists, psychiatrists, neurologists, which are facing with depressed patients, more than 1,000 professionals, and they asked to fill in the questionnaire, and also, according to the survey, a very interesting online survey, we can see that their view on depression and view on the aims of treatment must be very different from the psychiatrist or healthcare professional perspective and patient perspective. Firstly, there are big difference, statistically, meaning a difference between psychiatrists and psychology professionals. Specialists in general underestimate the symptoms of all 3 phases of depression during remission. We can see Also, there are big difference between patients and professionals in assessing forgetfulness, the very important cognitive domain which can predict outcomes of depressions. And we have to focus much more on this cognitive impairment as a part of our management, of our plan in treating and managing the cognitive managing depressive patients. Regarding social functioning, very interesting test FAST, which was proposed by Professor Betwe and his team from Barcelona, which assess different domains of functioning, cognitive functioning, labor, leisure, etc. For functioning domains, the difference in scores in functioning scores were greatest in the post-acute phase for the cognitive functioning in patients and professional cohort, and in the remission phase for the functioning domain. We can see that cognitive domain is the most differentiation domain in comparison in assessing by patients and professionals. Also, we can see this slide, and we can keep in mind while treating patients with depression. The difference are quite important in other symptoms, affective symptoms, somatic symptoms, cognitive symptoms are more important also in treatment. A cognition, very popular slide. We can see different conferences, which we see that there are different domains which contribute a lot as protective factors, resilient factors, or factors that can contribute for developing of depressive states from lifelong, from life perspective, from before birth at the early age, adolescent periods, and adults and retirement. Different factors can contribute as a protective and in favor of having depression. Also, today we are focusing not only on scales which are quite popular, but quite old, and Hamilton scale, or iceberg, and other scales. And today also need to assess our patients not only by ourselves as clinicians, but also we have to propose them the self questionnaires. And COBRA, one of the instruments which help us to assess these cognitive complaints. And negative symptoms are another examples. Since Kaplan time, Bleuler time, being clinicians, we suggested that negative symptoms are the basic symptoms of schizophrenia, and only we as clinicians can assess them better than anything else in public, generally speaking, and our patients can assess better. But according to some instruments, this instrument and other instrument also can tell us that patients can assess, can estimate the conditions not bad, and we should also we even in assessing negative symptoms we have to think about patients' attitudes, etc., etc. What artificial intelligence, machine learning can help us to diagnose and treat their mental disorders. Today, Food and Drug Administration approved just only 2 biomarkers which helped clinicians to manage a treatment plan for patients. First test, FDA approved 23andMe genetic test for analyzing DNA extracted from saliva by a person herself, and informing the patient that he has mutations, certain genes that are associated with the ability to metabolize certain drugs And also another test, carbamazepine. Before starting carbamazepine, people of Asian origin are advised to have a genetic test to avoid serious skin reaction. I'm not going to talk about genetics. It's not my topic today, but unfortunately, just only 2 tests we can use in our routine practice. Other tests, which even in Russia, myself sometimes I'm using for my genetic tests, help me to understand better which antidepressants and antipsychotic I have to prescribe my patients after 2 fails, for example, and let's say results, or my own opinion, it's quite contradictory. Sometimes it helps me, sometimes no. Today, all these tests are future, right? Also biomarkers, there are different biomarkers, clinical biomarkers, imaging, genetic, epigenetic, other biomarkers, which maybe in the near future can help us to treat better our patients. But today, unfortunately, it's in the work, in the progression of using this test in clinical practice, even for depression disorder. In other fields, firstly in cardiology, in medicine, general medicine, FDA and some other regulatory organs in America, they approved some tests. For example, machine learning can screen retina, can have retinal scans to predict heart disease, analyzing blood vessels in the back of the eye to predict the risk factors, and it help us to predict heart attack, etc., etc. But in psychiatry, we just only have few articles regarding the use of artificial intellect as a predictive instrument. Some disorders also in these articles. We also, when we use when we scan retinal arteries, which may there is some relationship between cerebral vascularity and fibrinolysis. It must be a marker of schizophrenia and bipolar disorder, but it's not now. It's a future, but it's more important to use a different app which we can download from Apple Store, from Google Play, which detect, for example, arterial fibrillation using built-in technology. Today I'm talking about general medicine and actigraphy, which during all the day it scan our movement, and there are professional devices which can help us to understand better the phase of sleep, etc., etc. And professional device like I'm using this device that helped me to understand better my sleep, and I'm thinking a lot after each night, which do I need medicine? Do I correct something in my diet? Something in, for example, what cups of coffee I need to drink to improve my sleep without taking medicine, etc., etc. And there are a lot of different devices today. And it's very interesting article published 2 years ago, which where machine learning classifier of spoken language can reliably identify current or lifetime history of suicidality, depression with speaking of epilepsy. Just only few articles we can find. And also today, I know that a lot of psychiatrists researchers are working hard on using artificial intelligence in predicting severe mental disorder. Just some months ago, Popovich talked us a lot about her work with her team in Israel, which she not published this article about using voice and speech to predict psychosis. I know that Darius Vernon also is a big expert in linguistic, and it's also a very intriguing area in psychiatry, and in the near future it may help us to diagnose psychiatric conditions. About mobile apps, even now, if, for example, we write depression diagnosis test, as we can have this link, and persons will propose to use a very popular PHQ-9 test and self-help test, which can help you decide what to do. And if you have, for example, more than mild depression or severe depression, more than 9 scores on this test, you will be delivered to the specific telephone. In America, unfortunately, we don't have this sort of instrument here in Russia, but I think it's in the future we'll have the same. But before using mobile apps, firstly, since Kraepelin, because Kraepelin in his routine work, he and his colleague used different charts to understand better mood of his patients, low moods and elevated and weighted mood, etc. And today in America, in Great Britain, there are different charts. I know that Guy Goodwin, professor of University of Oxford, also he worked hardly on using these charts, which help to understand better the level of severity of depression or mood, depression, affect mood, anxiety, irritability, also, which can help us to understand better whether we are facing of mixed state, as Dr. Varminda told before, or must be something else. But unfortunately, it's quite important. But today, it's not easy for our patients to use these charts and different charts, because all of us, most of our patients are using mobile phones. It's better to use apps rather than to draw each day to assess the conditions by having mark on this chart. It's good, but let's say it's quite old-fashioned. And we're talking about digital era today, which includes mobile health, including mobile apps, which can be active where patients are part of this process, and he helps the clinicians to understand better by giving information about the mood, about the contact, etc. There are different parts of mobile health, mood self-rating, when they're using mobile apps, diary apps, which use contacts, and wellness apps, which help the clients to understand better by sending them some messages that you should do, for example, physical exercises, etc., etc. Health information technology, telehealth. Even now, we're using telehealth, telemedicine. It's a part of our routine practice, even in Russia, and it's quite acceptable for patients. And in our country, long country, telemedicine, it's a part of our life. And of course, wearable medical devices. There are some advantages and disadvantages of mental health apps. Firstly, can be easily adopted for most of people which prefer to use computer and apps when they visit psychiatrists in the home. Some apps can gather better without any help from the user. For example, receive information from a large number of individuals and help us also to understand better what's wrong with the patients. Most, not all, but some apps are cost-free, and technology can offer treatment for patients in different areas. It's also quite relevant for Russia and for poor countries, also for developing countries, or to individuals in terms of intensive needs. This technology can provide 24 hours monitoring and intervention support, can complement using therapy. But firstly, the main issue when we're talking about apps are the privacy. And apps manage sensitive personal data, and some people can hack this information, and they can know you better than yourself, and they can have these informations in different areas, especially in many countries, South Korea, for example, and other countries. And mental apps offer the same treatment program to all users, but also we know that patients are quite different from each other, and it's not the case to use the same programs, same piece of advice for all patients. And of course, we have low lack of or low evidence of effectiveness of apps. Later, I will focus on just on some apps which will be validated in different countries. And before I was talking about cognitive impairment as a part of depressions, and the difference between clinicians and mental health professionals, and think it's a very interesting tool created by Mood Disorder Society, Professor McIntyre from Toronto, and his talks, which consist of tests and also questionnaire and tests which assess different function, executive function, attention, working memory, etc. And after maybe 15 minutes later, you as a doctor can see instruments which help you to understand better the level of functional cognitive impairment, etc., and help you to use a good treatment plan. Today, it's an overview of Hidalgo-Mazzei from the team of Vita from Barcelona, and in his review, he just him there are only 4 or 5 or much more, maybe nowadays more than 10 instruments which can help you to improve symptoms, which can help you to prevent relapse, which can help you to detect and predict mood changes. And most of these tests are quite feasible, and there are some randomized control trials of these tests. And today, just a very interesting example of this app, so-called simple projects, self-monitor and psychoeducation in bipolar patients with the smartphone applications. It is very highly available and user-friendly and not costly monitoring. Before, maybe 2 years ago, it was translated into English from Spain, and unfortunately, we don't have translation of this app in Russian. And this app gather information during the day, also about context, about assessing the mood, also. They do according to this information. Per person can get an SMS from this app, which says that you need to do exercises if or you have a very high level of suicide risk, or for example, simple app can improve biological rhythms in bipolar disorder because they can use so-called brain. Brain means rhythms, biological rhythms interview of assessing for neuropsychiatry, and eating pattern, predominant rhythm, social rhythm, activity, sleeps, and according to this data, they give you information about what should you do, and it has positive effect on psychoeducation. And using this app during 3 months, it may help you to improve your sleep, improve your habits in general, and also it can remind you the need to take lithium, for example, so three times a day, and you need to have to give a test on lithium, and of course it is more reasonable than using psychoeducation because in many countries, in Russia, here in Moscow, we have just only some teams which are specialized in cognitive remediation in bipolar disorder, and maybe using such smartphone apps can improve your different domains which are quite important for functionality without and if in conclusion, if we're talking about mobile mental health, which includes information from apps, from your smartphone, can also can analyze not only your, let's say, your sleep, let's say your distance, your number of your calls, but also they can assess your voice, timbre, voice. So if we are talking, if we are very talkative, for example, if you touch your screen with a heart, and it might be, let's say, as a trigger for it may trigger for risk of psychosis, or depressions, or mania, and the issue that what should we do? Mood diary also trackers, which now translated into Russian, and you can download in Google Play. It's not quite big, not quite informative, but a simple app. It helps also to assess mood and context and give you a very simple message. A mood enhancing app without therapist. It's, let's say, also we can have here in translated into Russians. It's based on the cognitive behavioral therapy, and it includes stability techniques, and for example, you can get a message which help you to understand better your own condition. And just only 2 years ago, it was launched by the Union of Psychiatric. Say, I don't remember the name of this organization. Oh, yes, the Union of Mental Health, and Natalia Kryushnikova, the leader of this organization, very important organizations, which also propose some apps for treating, for managing depression, so-called antidepressant, antidepressia app. You should easily download from Google app, and also you can focus in on your thinking. You can focus in what should you do. For example, you can advise you to for example, to go to drink wine, champagne. You need to touch something. You need to go outside, etc., regarding information that you get. And also, when we're talking, for example, about suicidality, we have to clarify some very important issues. how can, for example, can apps be connected to alert system when acute suicide risk suddenly increases? What should we do? It's not easy to balance between privacy on the hand and our psychiatrists. We should do something which we know that the risk is quite high according to information which we get from apps. Can mental health derived patient data be integrated into the algorithm leading patient to crisis management services and other urgent care resources? Also, in generally speaking, the big gap when we're talking about apps between privacy and our work as psychiatrists. And also the last slide, Wiki, it's my also my maybe very popular, my favorite trainer, which can use people, and I'm a user of this app for about 10 months, and I know that following this test, very simple test, I can improve my my social care skills, my sleep, etc., etc. It is, let's say, it's very important when you use when being a doctor and you recommend to use some mobile apps to patients, you need to understand better them, not all of them, but some of them. We can, for example, antidepressant, simple mobile apps. Before you need to understand better which you have to wait from your patient, from clients. Yes, but also when we are generally speaking, when people are creating these apps, they need information from patients, from clients, and clients and patients must be a part of team, because only them can understand better how patients with suicidal ideation think, what they think after suicidal attempts. And doctors, patients, caregivers must be the part of these teams while we creating mobile apps. It's also just published an article 2 years ago about requirement for creating mobile apps. And how can we integrate different data, big data, internet-based, firstly, information from computing, from smartphone, from devices, genetic information, and clinical observation, of course, biomarkers, and also it's a part of our big diagnosis, which called precise medicine, precise diagnosis, and also combining all these parts so we can understand better, and we can create better plan for our patients. And the last slide, at the proposal of Thomas Insel, the previous president of National Institute of Mental Health. Now he's working in the industry, and so-called digital phenotyping, which involve collecting sensor, keyboard, voice, speech data from smartphone to measure behavior, cognition, and mood. And digital phenotyping could become a potential path to measurement-based care, allowing care managers to monitor remission and relapse, potentially printing emergency department within hospitalization. Also, as I mentioned before, privacy, and this must be the big issue in using this information in routine practice. But of course, it's psychiatry. It's nowadays it's a part of our life, and in the near future, as the great Italian psychiatry Alessandro Serretti published the Present and Future Precise Medicine Psychiatry 2 years ago, the future will be based on biological determinants. However, until such an interesting but still futuristic aim will be reached, at present we may only rely on clinical feature to guide our individualized prescription, which is currently still frequently based on personal opinion and subjective previous experience. But luckily, some mobile apps can help understand better our patients. And to conclude, patient and physical perspective on the cognitions, goals of therapy and prognosis can vary greatly. There are no reproductive clinical use of biomarkers in psychiatry, but only two, maybe, which are important in context of pharmacology. The potential of digital technology in psychiatry has awakened many hopes, but despite encouraging results, research in this area is too early to be applied in real practice. Computerized psychiatry is a valuable field that needs to be further explored, and also artificial intelligence is likely to change psychiatry as we know it. It is now it is changing psychiatry, and maybe in 10 years period we will live in a different reality that we live now. Thank you.
Dear Alexey, thank you very much. It's really impressive lecture on a really made step in a new era. And yes, we're expecting what will happen in 10 years, as you say, regarding digital mental health and artificial intelligence, which will guide us another way, perhaps. And it's a great collaboration with the Union of Mental Health and Natalia Triushnikova, who really does a great job on these digital mental health technologies. And I would like to ask maybe one question about the security of services of telepsychiatry, of this services, of the security of services. How can we provide the security when we use applications or telepsychiatrists? So we are talking about some secure IT services, servers, or are we opening all the data about mental health state of the population? What can I say?
It is mostly one interesting and challenging issue, as you gotta ask. Even maybe today, FDA doesn't approve any apps in psychiatry, and there are some they approved in cardiology, but not in psychiatry. And also they are using a lot about security. I don't know how to answer your questions, because we need to save our information from our patients. But on the other hand, when we're using telephone, most of us are using Chinese telephones, yes. And as you know, that American Donald Trump, half a year, maybe 1 year ago, he banned Huawei that because they collect information about Americans, and they can use in different ways. And we don't know exactly. We know that it's a part of our life, and our smartphone are gathering information all the time. Yes, and how they use this information, and maybe if maybe, and I don't know how to answer, but it's most
actually we also know.
Someone else knows about the ways of save information from our patients. Yes. Maybe it's one of the biggest limitation to share these apps, but agents and not only doctors and caregivers know a lot about patients, but everyone else can hack your information and share information. It's a personal data, it's a conditions, it's your how do you sleep. For example, if we use this data in business, if your business partner they can know this information.
Okay.
very dangerous, very dangerous.
Yes, very dangerous, but as you say, it's a part of our life. We are very open now and very fragile, actually, because we open much information while using these digital technologies. But of course, there are some cross points regarding security of data and ethics in psychiatry. But what can we do? Actually, as you said, that you showed on one of your slides, there are advantages and disadvantages of everything, and digital mental health technologies as well. But if to integrate what we have been discussing today, maybe we could think about some application about mixed states. Yes. And maybe we can have develop some collaboration with you and Professor Giuseppe Taormina, and as Giuseppe have so much information and contacts in Europe, and have their literature, education literature in many languages, so we can also develop some education, at least education, mental health technologies, and maybe measuring mixed states if we go into this field, and maybe in collaboration with Natalia Triushnikova, we can arrange some project. Thank you very much. We are very impressed by both of the lectures, and we will, if you don't mind, if you agree, we then share all this information via YouTube channel of our university for the audience of students, doctors, researchers, and really we hope for future collaboration with you, Professor Giuseppe Taormina, and you, Associate Professor Alexey Pavlichenko. Thank you very much. Thank you.
Thank you, all you.
Thank you, Daria. Yes.
So continue our day.
Yeah. Okay.
Keep in touch. Thank you.
Thank you.
Bye-bye.
Bye.
Bye, Giuseppe.